There's been a sort of evolving debate about what the best way to dose cisplatin is. Historically, we've used 100 milligrams per meter squared. It's been given every 3 weeks. And in the post-operative setting, that would have amounted to 2 doses. In the definitive setting, that would have amounted to 3 doses. And people have been concerned about the toxicity of this approach. It requires a lot of supportive care. It places patients at risk for renal and ototoxicity. And over time, there's emerged a consensus, which really was not built on a very firm foundation of evidence, that if you gave cisplatin 40 milligrams per meter squared per week, you could avoid some of the toxicity and you'd get the same total dose of cisplatin, so it would be equivalent. So there's a large head and neck cancer group at Tata Memorial Hospital in Mumbai, and the lead investigator for this trial was Vinita Narona. And what they did was they took 300 patients and randomly assigned them to 100 milligrams per meter squared or a weekly schedule. Now, they had extensive experience using weekly cisplatin at their institution, and they had concluded that in their environment, the best dose of cisplatin on a weekly schedule was 30 milligrams per meter squared. So that leads to a lower cumulative dose than the regimen that's being explored in the US with 40 milligrams per meter squared. And what they found was that for this group of patients, predominantly oral cavity, predominantly post-operative radiation, that 100 per meter squared of cisplatin was superior to the weekly dose. There were differences in the toxicity pattern, but one of the surprises from the trial was that the weekly cisplatin dose was not so much more tolerable than the high dose. So in the States, the move towards the weekly dose was driven by people's belief that it would be safer and easier for the patients to tolerate. There were some data from this study to say that the risk of hospitalization would be higher if you got the high dose cisplatin. And the first author described how they brought the patients back for hydration for 5 days in a row after the treatment. They saw them every week. It was the case that they provided a lot of supportive care to get the good results that they got. However, they concluded that for their environment, 100 per meter squared is better than 30 per meter squared on a weekly basis. And I think the finding that the toxicity was not that different between the arms should cause American investigators to re-examine our assumptions about that. And when we have a patient who is fit for 100 per meter squared every 3 weeks, that is presumptively the standard of care for a lot of different settings. The discussant was Robert Haddad from the Dana-Farber, and he was very firm, the right dose is 100 per meter squared. I think there's still room for more trials. I'd like to see this repeated with 40 per meter squared per week, but for now the signal seems to be that 100 is a good dose.